Welcome to Active Aging. My name is Danielle Procopio and I'm your host today. Active Aging is continuing to look a little bit different as we are moving through the journey that is COVID. And I'm excited that today Patrick Klein is with us from Harbor Light Hospice and Palliative Care. And today we're going to talk a little bit about healthcare during the pandemic and kind of some of the trends that we're seeing as healthcare providers and what options are out there for people that might be a little bit hesitant to use some of the traditional means of getting better and finding some help with their health. So Pat, welcome to the show today.
Thank you very much. I'm glad to be here.
We're excited to have you. It's been a little while since Harbor Light has joined us on the show. I know this is your first time. I think Diane was with us last time talking a little bit about what was going on with everybody.
Yeah, Diane joined you last time, and I'm glad to be with you this time. I am sort of the person that handles the COVID here. So
I don't know if that's a blessing or a curse.
Well, it all depends on the day, actually.
Isn't that the truth?
Yes.
I know. And I'm assuming that things probably look a little bit different for you guys as well as for your clients since the last time you've been on with us with the introduction of COVID on the scene. So I'm excited to hear a little bit about what you guys have been up to. Before our viewers joined us, Pat and I were talking a little bit about COVID and kind of what has happened in the community as a result of the coronavirus and the threat that it does pose to everyone, but especially our senior population out there. I don't know about you, Pat, but over here at Shepherd, we've seen less people wanting to enter into nursing facilities, less people that are willing to come into assisted living. Our home health patients are very hesitant to go to their doctor's office. They're struggling even with a hospital visit. So what have you guys seen out in the community?
Well, in the community, a lot of people, they just are sort of nervous, especially when they have those comorbids, those heart disease, the lung disease, the diabetes, the things that make them more at risk for COVID. And they're afraid to go into the hospitals because the hospitals are, in their opinion, full of COVID. And they're afraid to go to their doctor's office because they don't want to get something and then that impede their ability to fight COVID off. So we've seen a lot more telehealth for providers and even for our palliative care program for our nurse practitioners. We've seen that in facilities, we've seen that in assisted livings, and we're trying to protect our elderly population as much as possible. You guys know that in your facilities because of visiting restrictions that have gone on at different times and outdoor visitations and change in some of the things that normally go on in a building. And we see that every day because our families want to take their loved ones home. Our families want that ability to care for them and see them every day. And they're truly afraid, like you said, to go in someplace where they think COVID might be around, where they might get exposed.
Absolutely.
And we can all do I call it my standard COVID announcement every day. Wash your hands, wear your mask, socially distance, do the right thing.
Right.
Do what you think is going to make you safe. And we have our people well prepared for COVID. Here at Harbor Light, right now, we're following the CMS and CDC guidelines. And we have yellow and orange counties, according to the state. So we're testing our employees every week. And we're providing them with the proper PPE, the N95s, the simple face masks, the gowns, the gloves, we call them bunny suits, if you will, the whole Tyvek suit if they need it. And we provide those not only to our patients, but also in cases for our families. If they need to go in and see a patient who's in a COVID unit, who's coming up on end of life, we provide that PPE not only for our people, but for the families as well, because that end of life time, there's nothing that replaces it for the hospice patients. For the palliative patients, we're seeing more use of home health and more use of ancillary services or community programs because they're afraid to go into the facilities. And that's just their impression right now.
Yeah,
the facilities do a wonderful job of keeping COVID at bay. They do. But it's just a perception. And unfortunately right now, perception's reality.
Oh, absolutely. I mean, I think that with as much warning as we were all given about going to the grocery store and, restaurants shut down, we weren't able to eat in a restaurant, or things that were very much commonplace for all of us to do every day, we now had to take serious precautions with. So to think that, in public places that, we have to be that careful, of course, in the place of healthcare provision, you need to be extra careful because that's where the sick people are. And I want to compliment our hospitals for a second. I think that, I'm very proud of the job that our hospitals have done. We've been very impressed with what we've seen from the hospitals. I think that they've done a great job of working with the local providers, and doing their best, of course, to keep their staff and their patients healthy when they're there. So I know, I always make the joke that it's a great day in healthcare when not too much goes wrong because they're pretty much like every day things are going wrong for us. But we were all as a community really tested in a new and different way for something completely unknown that I think most of us weren't prepared for. So to see everybody come together, from the hospitals and physicians and, healthcare providers that are in the home settings, such as hospice and home health, I just think, everybody's doing the best they can. And for the most part, they're doing a good job with what we know. So, it has been a lot. And I think that for anyone to be nervous about going to a healthcare provider is understandable, whether that's the hospital or the physician's office, to come into the skilled nursing and AL, even though we're all following the guidelines and we're doing our best with infection control. And for the most part, we've really, been able to keep those infections down, but I still completely understand the fear that is there. The hard part about that, and what I struggle with, is that then we have this whole population of people that doesn't want to go to the doctor or to the hospital or come into skilled nursing after an illness or an injury to do that rehabilitation. And what's happening to those people? How are they receiving health care? How are we making sure that they have what they need to recover safely and to stay healthy? So, and I think that's the great thing, is that we've got home health and we've got hospice, and you guys have palliative care out there. And so those have been some great resources for some people that have really needed care at a very critical time when they haven't been comfortable going to the traditional providers that they might have called in another circumstance.
Yeah, a lot of times, even for us, when we call our doctors, we're being offered telehealth instead of an in-person visit.
Yeah.
Because number one, it's allowing them to see actually more people and care for more people, but it's allowing them to do it in a safe way.
Mm-hmm.
When you guys go in with home health and we go in with palliative care to treat those chronic conditions that people have, the rapids of life, if you will, they're still seeking that aggressive care. They're still trying to get better. They're still trying to fix what's wrong. And by us coming in and actually being able to put eyes on them in their home, or do the telehealth with them, or assist them in managing their medications, that allows them and their healthcare provider to be more informed.
Absolutely.
Because we work together with their team. I mean, I joke that our patients have 15 or 20 doctors, but they have 4 or 5 maybe, or 6, but everyone wants the information about their patient. They want to do the best job for them. And in our palliative care program, we work with their provider, and we're there to help do those things when they need oxygen, or when they need home health care, or if they're starting to fall at home, and bringing in the people and the resources to help them get through that bump, get through that problem, and not having to go into the skilled facilities or the assisted living facilities, because right now they're nervous about that. And that's understandable. But the other side of it is, those facilities, for the most part, are protecting their patients quite well. They're actually doing better for them, because they're seeing these people over and over and over again the same day. They're seeing the families and dealing with the families. And we get to do that in home health and palliative care as well. And when it's time for hospice, we come in and we provide all that durable equipment, and the beds, the wheelchairs, the walkers, the shower benches, and what have you. And we help provide the medications and the aides and the social workers and the chaplains that can come in and see them, or even do the telehealth with them. One of the advantages that we found with the skilled facilities and the ALs, or the assisted livings, is when our staff goes in, we all carry iPhones and iPads, and we help the person actually FaceTime with their family.
Yeah.
So they get that time to talk to them and interact with them a little bit. And that's been more of a blessing for my staff than anything else, because they actually get to see that interaction between the family and the patient.
Yeah. Yeah, I must say technology has been a really important part of us all surviving COVID. When the governor put those orders into place back in March that put us in a position where we weren't able to allow visitors into our buildings, I know our families might struggle with this, but that was as difficult for us as it was for the residents and families. We never want to keep residents and families apart. And so, we thankfully had a good stock of iPads on hand that we've been able to use for FaceTime visits. It's great to hear that your staff is doing that as well with your patients, because I know every touch point where families able to see a loved one is so important, especially, when your staff is involved. If it is time for hospice, we know that the days are limited at that point. And so to know that you're in a position where you can't freely visit mom or grandma or, dad or your uncle, that's a hard pill to swallow. The visits are very different than what they are in normal circumstances. So I appreciate that your staff's taking the time to do that.
Well, we try to do what's right for the patient and for the family. And we try to get them to understand exactly where the patient is and what they want. The other thing we do is, as we're going through this, and if the patient dies, then we bring them into our bereavement program for 13 months after in the hospice program. And we actually do grief support groups online now.
Oh, wow.
We do them in person. Now we do either FaceTime or Zoom meetings for our bereavement groups.
Oh, wow.
So people can come together and actually share. We're utilizing the technology that we've been given. And I would much rather see somebody face to face. I would. And I would much rather be sitting there and being able to talk to everybody. Right now, we're having to do it with masks on and 6 feet apart.
Yeah.
So it makes it look a lot different. But you know what? In the end, we're here to take care of our patients and their families, because each one of them has a piece in this.
Absolutely.
And if we can't interact with them and can't help both of them out and both of them through this, then we're really not doing the best justice for our patients. And you guys know that because you've had events for the families for years, right? And you bring them in and you do things with the patients and the families, the Halloween things and the Christmas things and the Easter things and the concerts and everything else. We all do different things to help them out and to help them make contact with their family. And truly, that's what it's all about. COVID or not, people are people. And we have to do what's right for people. And, we make all these rules about you can't go into a facility, or you have to visit outside, or the governor changes those as the season changes and as the disease changes. And we all see the different things that have gone on and the businesses that have opened up and then closed back up. It's right now, we're not at normal, and we won't be at normal for a while. And unfortunately, we have to explore those different avenues. And in exploring those different avenues, I think we're actually making healthcare better.
I agree with that.
Yeah. And we're trying to do what we can to get everybody comfortable with the new technology and the new systems and the new way of doing things. Because I don't know about you, but, my dad carried a flip phone. For the longest time, he had a flip phone. And he'd talk on it, but that's about it. He couldn't text with it. But then we got him a smartphone, and he could text and watch his ball games and do everything else on it.
Whole new world.
Better than my kids could. So using and embracing the technology really helps the family to stay connected, and helps our providers to stay connected with both and make sure all the issues are being addressed. I mean, it's a brave new world.
Yeah, for everybody in so many ways. Yeah, I know that, life looks just so different right now. And, I'm glad to hear you say that it's going to be a little while. No, I mean, I take that back. I'm not glad to hear you say it's going to be a little while, but that's my suspicion as well, that it is going to probably be a little bit of time before things look like they used to, if they ever again look like they used to. I think that there have been some silver linings that we've learned through COVID that will probably outlast COVID and stick around. And there's some good lessons that we learned, but unfortunately, the sad part is for right now, we're still getting used to everything and trying to manage the new normal, temporary or not. It's a lot to take in.
It is a lot to take in. But if you think back to what we were taught when we were kids with dealing with the flu, what they always tell you, stay 10 feet away from your friends that are sick, wave to them from across the room, wash your hands, sneeze and cough into your elbow. And if you're sick, stay home.
Absolutely.
I mean, we're basically doing the same thing.
It's the truth.
And if you think about it, while this is a pandemic and it is worldwide, every year we deal with the flu. And one of the things, and I hate to steal your program and go off beat a little bit.
No, you're totally fine.
Flu vaccines are very important,
Yes,
especially
they are.
And I say that because a lot of people aren't wanting to get their flu vaccine early. It used to be, you go vote and get your flu vaccine. But this year we want you to get a little bit earlier because we want you to be protected against the flu as early as possible, because we don't want you getting flu-like symptoms and then getting lumped into the COVID group.
Right.
And the other thing is we want to try and prevent that spread of the flu as much as possible. Just like we're trying to prevent COVID, it's transmitted basically in the same means. And we want to try and keep our patients and their families and our communities as healthy as possible. So that's why I'm sort of veering off to the left a little bit, and I apologize. But the flu vaccine is
No,
very
you're
important
totally
too.
fine. No, I mean, flu season's coming. And so I keep saying that, it seemed like we had a handle on things for a little while. And so people are like, things are getting better. And I was like, nope, flu season's coming, and I think it is going to be hard. Like even when you look at our schools, when a child presents with flu-like symptoms, flu-like is COVID-like. And so how do you delineate between COVID and the flu until you're able to take a test? And, and it's the same is going to happen in our senior centers and in our hospitals. You're going to have to take those COVID precautions when people are actually sick with the flu. So hopefully all this hand washing and mask wearing and, all these other precautions we're taking, social distancing, will have a positive impact on our flu season, and you'll see less flu, but it is critical that everybody gets their flu shot.
I'm sort of chuckling at you because last night I got a FaceTime call with my grandson. He said, "I'm being put in quarantine, Grandpa."
Oh no.
Well, my daughter's a nurse also, and he had a runny nose and a slight temperature. It wasn't even what I call a fever.
Yeah.
But she quarantined him to the guest room, and he's going to see his doctor today. But it's a protection, and it's something that we have to look at and deal with every day now.
Absolutely.
And we have to make sure that everybody's safe, and we have to make sure that our kids are safe as well, not only just the older adults, but even the kids.
Oh yeah.
Because I don't know a 5-year-old that likes to keep a mask on.
No, none of them do.
And we got to do what's right for everybody.
Yeah.
That's the bottom line.
And it's hard. So I have a 6-year-old, and so she just started kindergarten this year. And most people know my daughter has special needs, so we have some extra stuff that we're dealing with as she enters school. And she had a runny nose the first week of school, and she did indeed come home. She got sent home by the nurse because they were taking all the precautions, but she's having a heck of a time keeping that mask on. And so and so we keep working on it at home, but that's what we keep telling her, and we tell our older son, and everybody I work with, you might be fine, and if you get COVID, you might be okay and you might survive it, but if you're not wearing that mask and you get somebody else sick, there's lots of people out there that can't handle having COVID. And so we have to be responsible to make sure they stay healthy, and the same with the flu. So hopefully everybody's listened to our soapbox and they get their flu shots, Pat.
Yeah, my standard COVID announcement every day. Yeah. But honestly, we still have to keep that front and foremost in our thoughts, because we get lax. we get to the point where it's like, oh, okay, I won't wash my hands. Okay, I won't do this. Oh, but you know what? When we get lax, that's when problems arise. And we have to repeat this and do this every day.
Mhm.
I've been in emergency management for a long time, and we've drilled and drilled and drilled with the health departments and with hospitals on pandemics for years. And we've had those plans in place. We're actually living our plan now. And we're seeing where our pre-planning fell short. And we're seeing where our pre-planning actually was right on the money.
Mhm.
But we have to take those plans and we have to take those precautions to keep everybody safe.
Absolutely.
Doing that, a lot of it is doing it at home now. And a lot of it is bringing in those outside resources, like your home health, like physical therapy, like the palliative program, or even hospice if needed.
Mhm.
And doing those virtual visits and keeping everybody safe and everybody healthy and happy and trying to fix those problems.
Yeah. And I think I'd like to take a little bit of time and delve into the palliative program. I think a lot of our viewers are probably familiar with hospice, even if you don't know the finer details. You know that hospice is a service that you get typically in that end of lifetime. You know, the general term is about, we expect 6 months
Right.
or less for someone when hospice is ready to come in. Sometimes it's more, sometimes it's less. So I know a lot of people are familiar with the concept of hospice, but they're not as familiar with palliative care. Or a lot of times when we're talking with families, they tend to think palliative care is lumped in with hospice. They don't understand it's a separate service. So can you tell us a little bit about palliative care and kind of what that means and who would qualify?
Sure. I like to paint things in a picture, if you would. At the end of life is a waterfall. That's where hospice is. Upstream, where you start having problems in life, but we call those rapids of life, if you will. That's where palliative care is. That's where you're having problems with your heart failure or your respiratory problems, or you have cancer, or you're having problems with your kidneys, and you're actually seeking aggressive care. Okay. Palliative care is there to manage those symptoms that come along with it. So we're there to take care of the nausea, the shortness of breath, the fluid overload, and we're there to work with your doctor. So we have a cheat sheet, if you will, and it has the major disease processes at the top, but it has the things in the middle section that are the symptoms of them: the tiredness, the weakness, the fatigue, the shortness of breath, the nausea, the vomiting, things like that. And when I do the presentations and I hand those out, I always tell people, you probably qualify for palliative care because you have 5 or more of these symptoms, but you don't have that life-limiting disease or that terminal prognosis. And we probably all qualify at the end of a bad day. But guess what? Palliative care is there to fill in those gaps. To a lot of times when they're in the hospital, they get a consult with palliative care to manage pain or nausea or a symptom. When they come out of the hospital, palliative care is a nurse practitioner and a social worker that come and see them at home, or in this case, virtually sometimes. And they're there to work with your doctor and your care team. And we can stay with that person and manage those symptoms even when they're getting better, to assure that they're in the right path and they stay in the right path. And all we do is start spacing our visits out a little bit more so that we're sure that the plan we put you on actually works. Think about a heart failure patient that goes home, or any patient actually, and they're given their meds from the hospital. They're given their list of 10 meds that they're on now, and they go home and they have that Tupperware dish of the 15 meds they were on before, and then they go to the cupboard and they have another dish of about 20 meds that they were on before that.
Yep.
And they don't know which ones to take, and they pull them all out and they said, well, I'm gonna take them all, or I'm not gonna take any of them because I don't know what to do. Or they can't understand why they're in heart failure when they have a truck bed full of Mountain Dew cans.
Mm-hmm.
We can go in the home and actually see what's going on, and we actually do a benefit for them, because we can manage those medications and make sure they're on the right medications and make sure that they're taking them in a way that actually fits with their life. you know, in facilities and at the hospital, they're on hospital time, if you will. When we're at home, we're not on hospital time.
No,
We're
we
on
are
we're
not.
on our own time. We like our pajamas and we like to stay in them until, like, 10, 11 in the morning, and then we're going to get ready for the day and take our morning meds. At the hospital, you're taking those morning meds at 7, 8 o'clock in the morning.
Right.
And when we tell you take them in the morning at night, or take them every 3 times a day, your 3 times a day at home may be a little bit different than the 3 times a day at the hospital.
It most likely is, yeah.
Most likely is, and in most people's lives it is, because we do things on our time.
Right.
I always tell people there's hospital time, your time, and then there's real time, and never the three shall meet, because we're all on our own clock, right? And we all take our medicines our own way, but the doctor at the hospital doesn't know that.
Right.
And they don't see the fact that, you like to snack on chips late at night, or you like your soda, because at the hospital you have a meal tray prepared for you, right? We don't have those choices.
Right.
And the palliative team comes in and they look at all those things. They look at your medications, and they look at the fact of, all right, you've seen your cardiologist for this, and you've seen your endocrinologist for this, and you've seen the rheumatologist for this, and they've all prescribed something different. And we all hope that, and we are all supposed to check the meds from the other doctor.
Right.
And the other provider. And sorry, I'm in my office. They forget that I'm on a phone call. So they're all looking at things in a different way. And they're prescribing this because it's going to manage their symptom that they're treating. But sometimes those two meds don't work well together.
Right.
And I use an example of a lady that we brought on when the palliative program first started. And she was in a skilled nursing facility, and she was tired all the time, and she wasn't eating. And we went in and we actually just looked at her meds and adjusted 2 meds and put her on something different. And all of a sudden she's eating, and then she has energy, and then she succeeded at her therapy and she went home. So we can work that same thing at home in an assisted living or a skilled facility, we're that extra layer of care in the palliative program.
Yeah.
And you don't have in your last 6 months.
No, you don't. And I think that's one of my favorite things about the palliative care program is that, in the land of hospice, you have to make that choice. I am no longer going to seek aggressive treatment, or
Right.
I am done with therapy and now I'm going to opt for hospice. There's some hard choices that have to be made. And one of my favorite things about palliative, which I was so shocked to find out, is how you can have palliative care services parallel to other services. So if you come into Shepherd of the Valley and you have skilled therapy and you're getting your rehabilitation with your therapist and your nurses are taking care of you, we can call palliative care if you have a complex situation or pain management issues, or just need your meds looked at, and you can kind of work alongside of us to resolve that. And the same for home health. If we have a patient who goes home or comes out of the hospital and needs home health services, we're able to collaborate with palliative care to make sure that we're doing the best things that we can. So it's a great situation if you're a patient who wants to stay at home, because you can have the best of both worlds. You can bring in, home health and have the therapy and have the nurse there and an aide to help with bathing, but then you also can have the specialty skills that are made available by your nurse practitioner and your social worker that can kind of coordinate that piece and make sure that all the physicians are on the same page and that we're doing our best to make you feel your best.
And the other thing with the palliative program is home health can come in and they're there to manage a problem.
Right.
Okay? So they're there to manage a wound or to get you up and ambulating or do a specific item for you. The palliative program can stay long after home health is gone. And if you need re-referred to home health, we can do that.